What's just happening, Jack? Can you tell me what diabetic ketoacidosis is?
Well, diabetic ketoacidosis is a complication of diabetes. It occurs when there's an insufficient amount of insulin for the demand of the body's glucose needs. So that could be for a variety of reasons. They could miss their insulin dose. There could be a stress factor that's caused them to need more glucose than what they have insulin in the body. So infection, drugs and alcohol could also have that effect. The insufficient insulin for the demand then results in a fight or flight response. So stress hormones are released, which then begins, a cascade effect of the liver trying to metabolise ketones and glucose, so that the cells are getting glucose. So that kicks off like a starvation metabolism, where more and more ketones are being produced, but still no glucose or ketones are getting into the ketones are getting into the cells, but not quite as well. They're not producing the energy as well as what glucose would. Okay, so there's too many glucose in his body, and it'll start to dissolve into the bloodstream again, and that will produce hydrogen ions and ketone anions, and that will drastically lower the pH of the blood. The body will try and compensate by binding the hydrogen ions with bicarbonate via the kidneys until bicarbonate is completely depleted, and at that point that is when you're into ketoacidosis. Okay. Would you like to know some of the symptoms that he's shown and why? Well, the respiratory rate will go up, and that is because the body is trying to offload as much CO2 as possible to bring the acid back to neutral, the blood back from an acidic state. Again, the nausea and vomiting that you've seen with Jack, that is also the body trying to excrete the acid and trying to bring the pH up. The kidneys will accidentally start excreting ketones and glucose during filtration. Now, the way glucose works is that it draws with it water and potassium, which will then deplete the potassium in his body and result in polyuria and polydipsia that you'll see. The potassium being drawn out of the cells will result in arrhythmias. Well, it could result in arrhythmias if it's not handled quickly. Vasodilation that comes along with the lower pH in his body is a compensatory factor, coupled with his polyuria and polydipsia, will begin to show in increased heart rate due to the blood pressure lowering, and the blood pressure would reduce and hypovolemia could ensue.
So, if hypovolemia wasn't treated, what could happen?
Well, it could progress to hypovolemic shock. Hypovolemic shock is a life-threatening condition which is characterised by diminished circulating volume, resulting in inadequate tissue perfusion and generalised cellular hypoxia. Reduced circulating volume can be a cause of internal or external blood or fluid loss. This can be caused by excessive diarrhoea and vomiting and polyuria, which Jack's experiencing. This reduces the preload and stroke volume, resulting in reduced cardiac output. Reduced cardiac output causes a reduction in blood pressure, which causes a low tissue oxygenation. As cells are deprived of oxygen, their function becomes impaired, leading to cell damage and eventually to cell death. There are 4 stages of shock. The initial stage, which is often missed due to very little symptoms. There's a compensatory stage. This is the stage when the body's natural response is trying to help maintain homeostasis. The progressive stage is when the body's compensatory mechanisms begin to fail and other clinical symptoms begin to manifest, including multiple organ failure. The refractory stage is the latest stage and is usually irreversible. This can be identified as it does not respond to treatment. During the compensatory stage, baroreceptors within the aorta and carotid arteries detect a reduction in blood pressure and stimulate the sympathetic nervous system to increase heart rate and cause vasoconstriction. Initial signs of shock would be tachycardia. An increased heart rate is a compensatory mechanism to help maintain blood pressure. Cool and pale peripheries are caused by vasoconstriction and help direct flow to essential organs including the heart, the brain and the lungs. Increased respiratory rate is a compensatory mechanism triggered by several chemoreceptors to help maintain the body's metabolic demand and prevent tissue hypoxia. A reduced urine output is because kidneys are sensitive to a reduction in blood flow and secrete an enzyme called renin. During the renin-angiotensin-aldosterone system, kidneys increase the reabsorption of fluid, resulting in the reduced output. As shock progresses, anaerobic metabolism is unable to meet the demands for normal cellular activity and metabolic acidosis will worsen. Compensation begins to fail and blood pressure drops. As blood pressure drops, tissues are deprived and multiple organ failure ensues. Other symptoms can include changes in alertness. The patient may become confused, agitated, restless due to poor cerebral perfusion, shortness of breath due to poor gas exchange, cardiac arrhythmias due to the fluid and electrolyte loss, abdominal pain and nausea due to poor GI perfusion. So the main aim is to restore tissue perfusion by resuscitation and rapid fluid infusion to increase the circulating volume and allow adequate delivery of oxygen to the body's tissues. A cause for the hypovolemia must be identified to prevent the onset of irreversible shock and death. Jack is a 19-year-old type 1 diabetic with ongoing vomiting and reduced levels of consciousness. He has a NEWS of 16. An immediate and methodical assessment must be carried out. Jack is dehydrated with a metabolic acidosis, both of which can contribute to reduced conscious levels.
Hello, Jack.
A regular neurological assessment using the Glasgow Coma Scale should be carried out. He is also vomiting, which can compromise his airway and increase his risk of aspirating. An NG tube should be considered to remove gastric content, relieve nausea and reduce the risk of aspiration. His airway should be assessed regularly. This can be done by listening for an obstruction and looking in his mouth for any obstruction. A simple head tilt, chin lift manoeuvre can help maintain a clear airway. However, ongoing assessment must continue. If his airway became compromised with vomit or excess secretions, suction can be used to expel this. However, an artificial airway, such as a gel or an eye gel, should be considered if the patency of his airway became compromised. Jack is at risk of deteriorating very quickly, so invasive ventilation must be considered if his airway became difficult to manage and he became unconscious. This can be done using an endotracheal tube. Jack is experiencing breathlessness and has a respiratory rate of 30 breaths per minute. He is also hypoxic as his oxygen saturation levels are sitting at 87%. He is hyperventilating, which indicates he's working harder to correct a possible acidosis. He should be assisted to a comfortable position if possible, which will help to optimise his lung capacity. High flow O2 should be commenced via a non-rebreather mask at 15 litres per minute. His SpO2 levels should be monitored continuously using a pulse oximeter and should be maintained above 95%. Your oxygen delivery should be adjusted as his oxygen levels improve as per guidelines. During this assessment, his chest should be observed for an equal rise and fall, as well as the depth of each breath for a minute, for a minimum of 1 minute every 30 minutes. His chest can be auscultated also to listen for any signs of edema or infection. His colour should be assessed, as paleness and blue tinge can indicate peripheral and or central cyanosis. His capillary refill time should be assessed, as this can help determine how well he is perfused and give an indication on how dehydrated he is. EBGs should also be taken at this stage. Jack's blood pressure should be monitored and recorded. He is hypotensive due to the rise in blood glucose levels. This causes osmotic diuresis and polyuria, contributing to excessive fluid loss. IV access should be gained using a large bore cannula, and IV fluids should be commenced to replace the lost fluids. 1 litre of crystalline fluid should be infused over 1 hour, and another litre should be administered in the second hour. His blood pressure should be reassessed during the infusions. Hypoglycemia facilitates water and potassium movement out of the cells, leading to intracellular dehydration and extracellular fluid accumulation. Accurate fluid input and output should be monitored to assess the degree of dehydration. Capillary refill time and skin turgor should also be assessed. 1 hourly blood glucose and ketone measurements and at least a 2-hourly serum potassium and bicarbonate measurements should be taken. Insulin should be infused based on the patient's weight at the same time as fluid replacement. Potassium replacement may also be considered if potassium falls below 5.5 millimoles per litre. The rate and regularity and quality of Jack's pulse should be monitored. Jack is tachycardic with a pulse rate of 130 beats per minute. This is a compensatory mechanism responding to a reduced cardiac output to maintain his BP. It is likely caused by an increase in stress hormones also. Due to the electrolyte loss, Jack should be placed on a continuous cardiac monitor to monitor his heart rate and rhythm and help detect any arrhythmias that may occur due to the imbalance of potassium and sodium. This should be documented every 30 minutes. A full blood count, urea and electrolytes, venous pH, blood gases, blood cultures and plasma glucose should be obtained and sent for analysis. A urine analysis and culture should also be carried out.
Continuous monitoring of his neurological status would be done using the Glasgow Coma scale. Every 30 minutes, check the pupil size and symmetry, reaction to voice, pain, ability to move equally. You would continue to monitor his blood glucose every hour while he has his insulin prescribed via the drip. You would also be exposing to check for a rash. At this point you could look for the CPR of the feet, documents as per guidelines in Tayside. You'll be checking temperature and reacting to any deterioration. So a blanket if he is cold due to the vasoconstriction, or if he is hot, it's a possible sign of infection. You would want to get a fan, remove the blanket and take blood cultures and start a broad spectrum antibiotic. At this point you could also consider any drugs or alcohol misuse that has contributed to his acidosis. You would continue to check for reactions to drugs that are being prescribed whilst in hospital and ensure that you use your TPAR correctly, noting any drug allergies before giving any new medications. After a clinical assessment, it is agreed that this should be escalated to the medical staff. He has a news of 16. Jodie, would you care to phone?
Yes, I'll pass over a handover just now.
Thank you.
Hello, my name is Jodie Smith. I'm a student nurse in the Clinical Scales Department at 9 Wells, calling in connection with a 19-year-old gentleman, Jack Frost. He was admitted this morning with increased drowsiness and vomiting. He is minimally responsive to voice and has an acetone smell from his breath. His background is Jack is a type 1 diabetic and has had a vomiting bug for the past 24 hours. His assessment, he is at a new score of 16 and has blood glucose of 22 moles per litre. He has a pulse rate of 138, a BP of 80/45. He has a respiratory rate of 30 and his oxygen saturation levels are 87%. His blood chemistry results show metabolic acidosis. I would like you to come in the next 15 minutes if that would be okay. Thank you. Hello, I'm sorry to bother you, but that's my friend's Roy. Are you able to tell me some information about him?
I'm not actually, Jack.
Oh, hold on a minute, I'll get a receipt. Okay. Come on, tell me about this. Tell me about
Jack's actually requested that his information about his hospital visit is not passed on to his parents.
Why is that? But I know him.
I know, but he doesn't want any information given to his parents. He only wants it passed on to his friend. And as nurses, we've got to respect that right. As the NMC code says in section 5, we owe this patient a duty of confidence and confidentiality. We cannot go further anyway to tell anybody else any information.
Even if I know him?
Even if you know him, we cannot pass on any information. If he so wishes to only have his friend know what's happening, then we have to abide by his wishes.
Well, that's it. I'll leave then.